Thank you very much for inviting me, and it's very interesting to see my city called Göteborg. It's Göteborg in Swedish, and I'm very, very, very honored, and thank you for letting me speak in English, because I'm from Los Angeles, but I never learned Spanish as a child in high school. Anyway, today I'm going to talk about comorbidities, and we heard from Professor Kanner about these psychosocial problems with people with epilepsy, and I'm going to try to put it in its context. Next slide. And so this is just my disclosures. Next. And the goals, what are we going to talk about, or what do I want you to go home with? And that is to understand all the comorbidities, not just the psychosocial ones that people have to deal with, and to understand how to pick the right anti-epileptic drug, anti-seizure drug really, for patients, which you almost have to be an artist nowadays and to pick the right drug for the right patient. You have to know the whole perspective of all the drugs, and you look at the patient and you say, maybe this one will be the best for you because of all of your other factors that you have. So we have to think of each patient as a special person, individualized therapy, we call it today, and that means that we have to have great knowledge of the tools that we are using to be able to match the right therapy to the right patient. Next. So what comorbidities do we have to consider? And you sort of have to keep this in your mind and just have it as a part of your life. And you have to think about, of course, the age and hormonal, are they going to have babies or not, menopause, et cetera, impotent problems with men, the metabolic issues, other medical comorbidities, especially with elderly patients, you get into real problems if you don't know what you're doing. Psychiatric comorbidities, we've heard a lot about toxicities of our drugs. So these drugs can also cause problems. You have all these different things going together and drug-drug interactions. Next. So what patients, when you think about what do patients want, because you also have to consider the person and what do they want, and that's 70%, they just want to be seizure-free that they can get back and drive. This is a terrible thing when you have to take away their driver's license. They want independence, they want to be able to work, they want to be able to manage in school and make a good result on their tests. They think that it's very socially embarrassing to have seizures in front of their colleagues and friends, of course. They're dependent on medication, and that they don't like. Mood and stress, and just not hurting themselves. Safety, not dying in a seizure. Now we're supposed to tell people now about SUDEP. And it's not so easy to tell a person, well, this is a pretty dangerous disease, and maybe in your sleep you can die. I mean, this is a very tough message, and you have to really package it in. But we're told in the American Epilepsy Society, we're told around the world that the patient should know about SUDEP. And there's always this controversy. Should you tell? Should you not tell? What type of psychiatric problems do you cause by telling, even? So they have a lot of problems. Now, the problem is that when we get a new drug out, in clinical trials, these are the perfect guys. And, the exclusion criteria is all psychiatric abnormalities that are ongoing and suicide risk and everything. Those are away. We have these people with almost no comorbidities. And then when the drug is out, we put it in every other patient, and they have everything that it's not been tested for. These drugs that are new, that are just going to be approved, like this year, we have several new drugs going to be approved, are not tested in all of these other people. And so how do you use it? What are you going to expect? You have no idea. Next. So epilepsy, anyway, getting back to this point, is more than seizures. And we all know this without even looking at some of these studies, especially by Gail Hesdorfer and her group, is that we know that people have cognitive deficits, have psychiatric problems, depression, psychosis we're dealing with all the time, aren't we? They have ADD, the children many type, and autism we know is a frequent friend of epilepsy, especially in children, and SUDEP and suicide. And our patients have lower rates of completing school. They can't get jobs, or the jobs are not what they want. It's hard to get married and almost impossible if you think about the Asian and Middle Eastern countries. This is a horrible thing to have epilepsy. It ruins your whole future life and parenthood. And we just saw that poor little baby with which was aborted in week 24 with damage because of valproate. I just got back from China. Most of the people there are given valproate as a first drug. Women, men, doesn't matter. Amazing. Next. So we have these comorbidities in patients, which I just talked about, and the suicide we heard, but also that the substance abuse. And many times when I talk to my patients, if they're not very aware of the fact that substance abuse is a problem, do drink a lot of alcohol or do have other activities, at least in Sweden anyway. I have to sit there and talk and go back very carefully to exactly what are they doing on the weekends to figure out why I'm not achieving seizure freedom or what's happening with my patients. Next. So these are the drugs that are available at the moment in Europe, which we would call anti-seizure drugs. I'm not talking about the other newer drugs like everolimus and those things which are for very specific epilepsy syndromes. These are the ones that we have on the charts coming next year. We have Epidiolex, and maybe we have another drug called Cenobamate. And so there's newer things coming all the time. Very exciting, but this is what we have right now. Next. And when you select a drug, you have to, within a minute, assess all of these problems while you're thinking about which drug to give the patient. And, what type of seizure type and syndrome is important. Are they going to get pregnant? That's really important. All those comorbidities. And can they manage a 2-time dosing, 1-time dosing? How is their life? And then you have to think about the drugs and especially the side effects and what type of profile we have for that. How safe are they? And then big problem, cost. This is our biggest problem, at least in Sweden. Everybody's hysterical now that we're spending too much money on drugs, and so we have to think about the cheapest drug. And this is not always easy because we want to give the patient the best thing to help them go forward. And then we have our clinics on us that you have to save money. You can't keep prescribing all these expensive drugs. The worst is MS, of course, but epilepsy is not far behind. Next. So, however, adverse events are very important. And when you're thinking about anti-epileptic drugs, and this is from Frank Gillum, who did a study looking at the quality of life and the amount of side effects a person had. And even if the person was seizure-free, they had a lot of side effects, or quality of life was really at the bottom. So we have to really think, okay, nice, you're seizure-free, but if you can't tolerate the drug, if you're angry and depressed and aggressive, this can ruin your life even more than the epilepsy itself. So it's like going on a tightrope. You can't fall to the right, you can't fall to the left. You have to find just the right thing for the patient. Next. So what are the chronic side effects? Because we're going to talk about what people have to live with. Next. And when you think about the older drugs, the oldest ones, which are still used extensively in India, China, all of Asia, is phenobarbital. And WHO says this is a drug you need to use in Africa and everything. And you have a lot of side effects, and the one that maybe one forgets is, with time, the Dupuytren's contraction and arm and shoulder arthritis, as it's very painful. And these are type of things you have to think about when you're giving phenobarbital. Next. And of course, with valproate, this is from my good friend Martin Brody. I love this picture because these are twins. And you can see which one is on valproate. And when she was off valproate, says Martin, then she reverted to looking like her sister. So, you know, when you give a drug that makes somebody fat, today this is really horrible, because that really makes them depressed if they all of a sudden blow up like a balloon. And because everybody wants to look good today, and you may solve the seizure freedom, but then you get them fat, and then they're depressed, and they have all sorts of other comorbidities because of that. So you have to be very careful in what you're doing there. Next. In valproate, we know all of these side effects. I just want to remind you, and what I didn't write there is that we now know that there are some very significant cognitive, almost dementia-like side effects on some people, and we've seen this in our hospital, and even with Parkinsonistic type of symptoms, when you take away the valproate, these disappear. So it's very important to always think, if somebody has dementia-like symptoms or movement disorders and they're on valproate, that is the #1 drug you take away, because they will often get a lot better. And so the thrombocytopenia, we have a lot of problem with as well. Young people with tremor, very embarrassing when they go out, when they're in school and their hands are shaking. You know, these are minor things, but really big for the patient. Next. Lamotrigine, you think, oh, well, lamotrigine has no problem. But even in lamotrigine, there's depression, and you have the skin reactions, of course, and you have tics, you have myoclonias, and you know, so you have to think about that. And topiramate, which I think is a very good drug if you use very low amounts, you do still get these cognitive changes, kidney stone, but you can use a weight loss. You know, this is a positive thing. Weight loss in a little thin person, not so good. But if you have a heavier person, it's not so bad to use some of these side effects for a positive effect, treating a comorbidity. Next. Then as we go on to the newer drugs, the list gets a little bit shorter as time goes on. So pregabalin, I don't think very many of us use it anymore. It hasn't been that effective drug that we thought it would be. But the weight gain is so much. Also, it's almost in the same category as valproate, and edema, and then the aggression. And so this is a drug that, at least in Sweden, we're really not using very much. And then levetiracetam, great drug, except for the aggression and the hostility, which you see in about 15% of the patients, and you really have to titrate it up slowly so you catch that before it gets out of hand. Because there have been some murders and other things related to levetiracetam. Next. And then the zonisamide, same thing with the aggression, depression, the rash, weight loss, which can be used. They've done double-blind studies showing that it does cause weight loss in a positive manner. And then oxcarbazepine, here we get into the hyponatremia part, and the vertigo, because it's a sodium channel antagonist. Next. And so then we get to eslicarbazepine, and the biggest thing was hyponatremia, which you see in 1 to 2% perampanel. You get weight gain and irritability, especially if you start with a big dose. Today I take 2 milligrams and increase it every month, and it's much better that way. Rufinamide causes weight loss, lacosamide, dizziness, brivaracetam, irritability not in the same ballpark, though, as levetiracetam. So we're getting a little bit less. Next. So one of the things for drug-drug interactions that we always have to think about, the older drugs are powerful inducers, inhibitors of liver enzymes, and if the patient has a comorbidity, taking other drugs, this is a real problem. I will show you later. The drugs that have no effect are listed on the right side here, and the newer ones are cosamide, perampanel, rafinamide, even carbazepine acetate if you have it in a dose under 1,200 milligrams. It's dose dependent, and if it's over, it's a weak inhibitor. Next. So what about elderly? See, we have a lot of people who have new onset epilepsy because of stroke and tumors and white matter intensities on the, and so we have a lot of, and when you treat these people, they have a lot of other disorders, and they're very sensitive to the degree, how much you're giving, what dose you're giving. And they're taking many drugs, and so this is a real problem in what to choose. Next. So this is just showing carbamazepine, which has been always a drug of choice. But these are two patients on simvastatin. So giving simvastatin, you see the higher curve that's a blood concentration during 24 hours. And when you add carbamazepine together with the simvastatin, then you see what a low concentration of simvastatin you get. And this is the same for chemotherapy. You know, you have a person on cancer drugs and you give them an enzyme inducer, then the blood concentration of those cancer drugs will be much less and the patient will not be treated in a proper manner. So if you decide to give an enzyme-inducing or an enzyme-inhibiting drug, you have to take blood concentrations all the time of the concomitant medications to make sure that they're stable and that they're not affected by these drug-drug interactions. Next. So then we have osteoporosis, also a problem in the elderly, even in younger people, but this is a real problem. And if you've been on an enzyme-inducing drug, then you have a risk of osteoporosis. And it seems, we still haven't done any really fantastic study on this, but it seems that the non-enzyme-inducing drugs are much better and cause less osteoporosis. This is a hypothesis. This is a trend. This is not proven in any double-blind double-blind study, comparative study. It is not. But if you think about vitamin D that is metabolized in the liver, anything that's not metabolized in the liver has to be better for bone metabolism. Next. So when should you use non-inducing anti-epileptic drugs as monotherapy or add-on? Well, almost all the time, to avoid chronic side effects, right? To avoid drug-drug interactions in concomitant illnesses, in the elderly, in people who have osteoporosis, and which I will not go into because you'll see this later, is for reproductive health, for libido issues, for men's health, for women's health, for pregnancy, etc. All of these things are extremely important. You have to think of the whole person when you're treating anybody. Next. So because, you know, you forget about, we're so busy thinking about depression and psychosis, we're forgetting about the medical comorbidities. And some of these, like cancer, which has just started, may cause autoimmune encephalopathies. And so, you know, you have to think about when a person comes in, why do they have epilepsy? They didn't hurt themselves, they don't have stroke, nothing. Got to think about, go look for the cancer. And we have I have one patient who just, we've been treating her for 4 years. She had an autoimmune encephalopathy, and we did a whole scan PET. Lo and behold, we see a a tumor in her tonsil with metastases. She has no symptoms. Nobody ever saw this. We now found the reason for her autoimmune encephalopathy. And that was really shocking, because we would never have found it if we didn't do a whole scan PET. And we should have found it 4 years ago. Now I don't know what's going to happen to her. Next. So if you look at the medical neurocomorbidities, people with epilepsy have higher rates of heart problem, hypertension, stroke, arthritis, migraine, ulcers. They're sicker than the regular population. It's not, people just don't have epilepsy. They have epilepsy plus. This is a plus disease. Next. And then, of course, we talked about the psychiatric comorbidities. I'm not going to go into them. Just to remind you also that panic attacks are very difficult to differentiate between epilepsy. People say, I have auras. I feel I'm going to have my seizure, and often it's panic attacks and not epilepsy. You keep increasing the drug, and you're really treating the wrong thing. So you have to, especially with panic attacks, I just want you to think about that in your patients. Next, which I'm sure you do anyway. And then we have the depressions that we talked about. Next. And so this is what Andy Canner talked about yesterday, about more than 20% of people will develop depression, and some think it's as high as 50 to 80%. So we have to think about that. We're not going to find the psychiatrists who are going to help us. I figured this out. Nobody's interested in my patients. I cannot get a psychiatrist to go and treat my depression, the depression in my patients. I have had to learn how to treat depression, unfortunately, because these people, at least in Sweden, fall between two chairs. Nobody wants a responsibility, and then they live miserable lives. You have to learn how to treat depression. I think we have to be experts in that as epileptologists. Next. And so bipolar disorders, they have to go to the psychiatrist for that. I can't really treat them, but many times the psychiatrist is already giving them these mood stabilizers, which are anti-epilepsy medicines. So that's already being treated many times. Next. So you can kill two birds with one stone, as they say. Then you have the psychosis, the ictal psychosis, the post-ictal, which is pretty dangerous, as Andy talked about, and then the interictal, which I think, as I've seen working for 30 years with my patients, and I see the same patients for 30 years, it comes with time, this interictal psychosis. It develops if you have active epilepsy for many years. This is what I believe, not tested, but still, I see this so often. Next. And so then just to end my talk and to just sort of leave that area and say that all of our patients, especially with the cognitive problems and all of the comorbidities that they're dealing with, adherence to their anti-epileptic drug is extremely important. If they don't take it, they get seizures. And it's amazing how many people don't take this seriously, and they say, well, I've been seizure-free for a while, so I didn't think I needed my drugs. And then they get seizures. But if you take it once a day, as you see on the far right, then compliance is, to the far left, you see compliance is much better, and then people have a better result with their seizure control. So next. So I'm just going to conclude that it's, we have 25 anti-epileptic drugs. It's like going to a market. Which product do you choose? And each time, think of a patient, you have to choose the right product, because if you don't, you get a lot of other problems associated with it, and you have to work on those. So I tried to give you an overview of what we have to deal with. Thank you very much.